Oof, look at this model right here. Okay, so check this thing out. If you're wondering what in the actual heck is that, this is the cervical two bone of a woolly mammoth. And a patient of mine, a patient that saw me through the social media platforms, sent this to me as a gift. Um, I operated on her. She flew into Dallas, met her in person. And truthfully, I really was not too interested in doing her case, but for real, she kind of talked me into it because she lived in a pretty rural area. And it was one of those things where if it wasn't me, then who would it be type of deal. And after telling her she needed to stay in town for a good while after her surgery, I did a somewhat complex spine surgery, incision about this big on the back of her neck, multi-level fusion. And she's been extraordinarily happy. She's written me, making sure her name's not on any of this, cover up this. She's written me one letter here, another letter here over the last several months and weeks. And she sent me this extremely cool woolly mammoth fossil. So this is the C2 bone, the cervical two bone. So it goes skull, occiput, C1, C2, C3, 4, 5, 6, 7, all the way down, and thoracic spine, lumbar spine. But this is what the spinal cord goes down through, kind of right down through here. So you're looking here, you have the vertebral arteries that go through these holes here. Pretty awesome gift. You can see even the joints. This is where the skull would go, and then sort of C3 would go. So I haven't made, be really careful with that, obviously. I haven't made a video for that yet, but that's one of the cooler, if not probably the coolest gift any patient's ever sent me. And I really appreciate it. So if she is watching, she knows I'm extraordinarily appreciative. And I just want to thank her once again for what a cool gift. And I'm glad she talked me into doing her surgery, and she knows exactly kind of what I mean by that. So with that all being said, if you have questions, jump in. Lori, good to see you. Thanks so much for the comment. My background, once again, I'm a spine surgeon here in Dallas, Texas. This is my hometown, born and raised here. I jump on these things for about 20 minutes at a time, maybe 30 minutes. I got a little kiddo who's taking a nap, and when he wakes up, you'll see me abruptly just cut everything off and turn everything off, and I got to run upstairs, and we'll kind of go from there. So with that, today, usually I have different topics I want to cover. Sometimes I talk about disc replacement. Sometimes I talk about spondylolisthesis. Sometimes I talk about disc herniations. Today's going to be a different one where I'm just only going to do Q&A, and I'll try to be as truthful as I can under a recorded setting where I don't maybe want to offend other doctors around the nation if they're doing some crazy stuff. I won't call out people necessarily, but ask me a question and I'll try to get to it. If I don't, you can always direct message me. This is not supposed to be marketing. This is not supposed to be me recruiting second opinions or anything like that. If you're interested in that stuff, just direct message me, and my office will connect you with how you need your x-rays and MRI to us, and we can knock out a telemed and get you better. And, I can even see the comments coming in. There's 5 to 10 people here who are saying that same thing to me now. And they, we've talked, I've operated on them, and they've done great. So I appreciate those people that are in here. So with that, let me just jump right to it. Lori, is there such a surgery using the ultrasonic technology to just clean out the facets and the foramen without moving bone structures? Yeah, I mean, definitely. If you go to either my Instagram or YouTube or TikTok and search the playlist, I have the ultrasonic spine surgery. I talk about it in detail. So I do a lot of ultrasonic spine surgeries all the time. Essentially, they're kind of like laminectomies or microdiscectomies or foraminotomies. They're all kind of the same procedure. It's just the different tools you use. I will say, I don't think, full disclosure, I don't know if necessarily using the ultrasonic tools any better than someone using a burr. It's just how I was trained. Instead of using that big spinny burr thing that could wrap up a nerve root, which is great, and they still is standard of care, and I still use it in many cases. The ultrasonic technology is great. It's just, frankly, it's expensive, so hospitals don't want to pay for it. Has disposables, so you're using a cost each case. Again, if you're in some big academic centers, they don't want to pay for that stuff, and it makes a really loud and annoying noise. So, but maybe I've already burned my ear so much I don't even hear it anymore. But whenever we have like new nurses in the room and stuff like that, they say that the noise is terrible, and I'm like, I don't even notice it anymore. But that's kind of part of it. One of my favorite questions coming in. Sorry, I'm not wearing my glasses right now, and I'm too lazy to go inside to get them. But it's from, is that Lou, L-U? How common is it to get a pars stress fracture? I don't actually know what percent of patients or people out there have that, but it's not uncommon. What that is essentially is from a hyperextension injury on your back. So hyperextension usually, and then you fracture the pars or the lamina, this piece right here. So see how this doesn't wiggle, doesn't wiggle, doesn't wiggle? This one wiggles. That's what a pars fracture is. Stress reaction, a little different. Maybe it hasn't gone all the way through yet, but that's what a pars fracture is. I'm in this series of posting. Maybe it's going to end up being like a 10-part or 12-part series about spondylolisthesis. I just put up part 5 last night on both YouTube and Instagram. So if you have spondylolisthesis, follow along and see the last 5 videos I've posted. I don't know how many total it's going to be. I haven't really finished it yet, but maybe like somewhere around 9 or 10. Where am I? I'm in Dallas, Texas, my hometown, born and raised here. My ortho or neuro, I jokingly say I'm handsome and funny. So of course I'm ortho, not neuro. That's part of the joke part, but hopefully people get that. I love your videos. I had a 1-level decompression. Still have lots of lunar pain. What do you mean lunar pain? Lunar pain, whichever that means. Generated from sitting, looking at a fusion as the next hope. From Francis. Not sure what to tell you on that. I wish you were totally better, but I don't know what to tell you. Usually like laminectomies aren't the best perfect thing for back pain. They're really good for they can't help with back pain, but really it's for the shooting down pain. Appreciate the likes and follows going on right here. If we can hammer those, the only reason I care is it just kind of helps generate this to other people who might be going through the same thing you're going. So if you could just hammer that, that would kind of help the fancy algorithm, the AI or whatever we want to call it, share this to other people, let them know that I'm preaching good stuff here. And I just think that kind of helps spread the good word. I think I do a pretty good job of educating, and the more people we can reach out to, the better. Sorry if you see me looking around. I got kiddos around, so just making sure they're all good. From Steve Johnson, pretty common name right there. I have a fusion in May. Wow, it's a long time away. Well, not that long. Oh, it's March already. Goodness, I didn't realize it was March. Okay, I have an L1 fusion in May from L4 to S1. One doctor said I had spondy. Another doctor said I don't need a fusion because I don't have spondy. What should I do? Steven, that's why patients hate spine surgeons, right? Because you see 2 doctors and you get 2 totally different opinions. What's that all about? That's why the hip and knee doctors have it really easy. You either have arthritis or you don't. You either get a hip replacement or you don't. I don't know how to answer your question. You either have spondy or you don't have spondy. It's kind of like sometimes in the medical world, when someone's debating stuff, we say you're either pregnant or you're not pregnant. There's no in between type of deal. So an X-ray lumbar film would show if you had spondylolisthesis or not. That's when one bone's sliding. Now, say you have spondylolisthesis, that does not mean you need a fusion. In fact, the video I posted yesterday, or the one I'm going to post, I can't remember if I posted it or not in the scheme of things, talks about when I fuse for spondy, when I don't fuse for spondy. In general, not 100% accurate. Degenerative spondylolisthesis don't necessarily always need a fusion. Likely they do, but not always. Isthmic, the pars fractures, do need a fusion. And then there's 4 other types, which you might have also. So it kind of depends on what type you have. I hope that gives you a little clarity there. From Denver, afternoon, doc. I've been dealing with DDD, tried injections, didn't work. Any suggestions? The one thing I want to tell you guys about injections is it's important when you're talking to the spine doctor to tell us kind of what it means by did it work or did it not work. And that was a really confusing statement. Somebody say that a little differently. If it worked for like 5 days, 5 weeks, or 5 months, technically it worked. Technically, they hit the spot. Technically, that's where your pain's coming from. You just happen to still be in pain. You just happen to have so much pathology there that it doesn't get better from the injections. So that's something I really have to kind of hammer patients on is, well, did it help for a while? They're like, oh my God, I got the injection at 4 or 5 and I had no pain for 2 weeks, but now I'm in pain. The injection didn't work. The injection was stupid. And I'm like, whoa, whoa, whoa. No, that shows me that 4 or 5 is your issue. Your MRI has stenosis at 2, 3, some stenosis at 5, 1, but 4 or 5 is what clinically it sounded like to me. 4 or 5 is what I was thinking about doing. The fact you got an injection at 4 or 5 means we don't need to go fix up here. We don't need to go fix down here. Let's hyper focus on L4, 5, fix 4, 5, whether that's fusion, non-fusion, disc replacement, foraminotomy, whatever fix means, and get in, get out. So not trying to critique, your description there, but I think in terms of when you talk to other spine surgeons, and that's kind of my goal here is to educate y'all, not belittling, but to help inform y'all. Think of it that way, help inform y'all is give them that information. It's really important to know if those injections helped even for a little while, because that helps kind of diagnose the issue. It really does. All right. So from Cruise Planner 02, that's a fun name. Sometimes I'm just reading these out as I see them. Arkansas here. I have a laminectomy on Monday with exploration, decompression of the spinal cord, and cauda equina. God, that's a lot of big words on your consent. You probably just have a laminectomy and you're going to do great. I don't know anything about your case, but the consent probably has all those words on it. That's like just a really, really detailed consent, and that's great. But if it's an elective case, exploration of the cauda equina is kind of a weird thing to put on the consent, but in an elective setting, but fine. Hit send before finish. Pain running down both legs very heavy. Tailbone when walking, L3, 4, 5. Yeah, well, and you're the one who's getting surgery. Great. You're going to do great. You probably have something called neurogenic claudication. Again, I'm not giving you a diagnosis. You already have mutt surgery coming up 2 days. You're going to do great. Congrats. I think you're going to do great. I don't want to talk you out of that at all. From Stacy, can't read the last thing. Is there a surgery for myelomalacia? Oops, sorry. Got a couple thousand people in these chats, so they're coming in fast. Is there a surgery for myelomalacia? Let you know as. I don't know what let you know as means. Yeah, there's definitely a surgery for myelomalacia. It's either disc replacements, fusions, either the two. It kind of depends on what level and a lot of other factors. I have a playlist called Myelomalacia, so subscribe, check those out, and you'll see it. Actually, I think that's on YouTube, so I'd go to YouTube to see that one. Thoracic disc pain in the stomach. That could definitely be true. Yep. Okay. Have you ever done an SI fusion? I'm having one done Monday. I have done SI joint fusions. Truthfully, I really don't do as many anymore. I used to do a couple a year, but then we hired my best friend into our group. He's only 1 year younger than me. I'm a young guy, but he's 1 year younger than me. And he does a ton of SI joint fusions. He was trained a lot doing SI joint fusions. So now I tell patients, I work them up. And then as I'm working up, I'm like, by the way, if this workup's positive and you need SI joint fusion, here you go. You're going to go see my best friend, AJ Rush. He's in my group also here at Texas Spine Consultants. So the one thing I usually say in general, if you're getting an SI joint fusion, I would highly recommend having a spine surgeon do that, because that's a spine surgery. That's part of, the pelvis, the SI joint, that's part of the spine. Pain doctors are great. Pain doctors are needed. Pain doctors are critical for a functioning role in society. But I don't think pain doctors should be doing spine surgeries. And I do definitely consider an SI joint fusion a spine surgery. Now, there's probably pain doctors out there that are better surgically than I am. Great. But in general, as a blanket statement, and I'm sure I'm wrong sometimes, if you live in a very rural area and there's only one pain doctor in town to help you, well, then that's who you need to use. But I think spine surgeons should do spine surgery, not pain doctors who go to weekend courses do spine surgery, because, maybe they can put that implant in and it's great. But I don't love the diagnostic workup sometimes. I don't love the bailout options if things go wrong. And I just think spine surgeons should do spine surgery. I don't think I should be criticized for that statement. But I do reserve my right to change my opinion on certain pain doctors, because certain ones are fantastic and maybe they could. Thoughts on ablation to treat spondylitis in L5? That sounds great. Brooklyn, thank you so much for the gifts. Hold off on giving me gifts, guys. I do really, really appreciate it. It's flattering, but TikTok takes all the money. YouTube takes a lot of the money. And, I'm a spine surgeon. I'm doing great. I'm not trying to do this for a financial standpoint. I'm just doing this to educate. So I do appreciate it, but scroll, find some dancing people in Africa trying to make money. They need your gifts more. So appreciate the gifts, but please don't send me any more. I really appreciate it. I don't mean that to sound rude or arrogant, but don't send me the gifts. But I do really appreciate it. Jesse and everyone else who's been sending them. Sarah, I do appreciate it, but no more, please. From 123 ABC, how common will artificial disc replacement be in 4-5? Doc is recommending dual level fusion, but I'm nervous. It's really a long debate. In general, I don't love disc replacements at 4-5 at all. I don't hate disc replacements at 5-1. And if you're like, well, what's the difference? Look, it's kind of like, it's not like the hip and the knee. I'd say like comparing the neck to the lumbar spine is more like comparing hip replacement to knee replacement. 4.5 and 5.1 are pretty darn similar. It's kind of the blood vessels that go down split. The biggest issue is if you ever need a revision, it's dangerous, but not crazy, to do a revision of that artificial disc replacement at L5S1 because your vessel split. You gotta go through the belly again. There's definitely risk, but like it's okay. It's not the end of the world. It's okay. At 4.5, those vessels, after you do that surgery, kind of scar down that area. It's one of the few things where you really could kill the patient from an elective spine surgery because you have to go in there and fix that 4.5 disc arthroplasty. I don't know. There's very few cases. You can go see some of my complex cases I've posted that I say no to, but that's one of them. Hold on. Here comes my cute little boy. What?
11-year-old one.
No, don't spoil it for me. You monster. I was going to watch that later. He just came in and ruined the new Mr. Beast for me. So hold on really quick. Let me check one thing here. They're headed home, but they're not home yet. And I remember. Okay, yeah. Okay. Well, he just ruined the new Mr. Beast episode for me, so that's fine. Okay, well, let's get right back to it. I'll try to get some questions out of here. I was given an intradiscal injection. It felt really for a few days. When I was given the epidural injection, didn't really feel any relief. What will help determine if I'm an ideal candidate for an ALIF? From Miguel. It's a tough question, actually. Let me kind of think about that. I don't know if I would. The intradiscal injection kind of throws me off there a little because if you got a relief from an intradiscal injection, you probably will do well from an ALIF because that's fixing that anterior disc space. There's just kind of a lot going on there without knowing all the information or giving you a diagnosis. It's also like, what is your pain? Is it back pain? Is it shooting down pain? Two different types of pain. So ALIFs do great. Miguel, you've given me some good info there. I just can't determine it just from that. There's just more I would need. What's my thoughts on neck pain? It's tough. You got to get to the diagnosis of what's causing neck pain. Another thing, when you have surgery for pars defect, when to have surgery for pars defect. The person who just asked that, sorry, your name's already gone off the screen. I'd have surgery when you can't hang out with your kids anymore. You can't go to soccer games with them. You can't go to work all the time. You can't fly in an airplane without having severe pain. You're taking medications, you've tried injections, or you have weakness. I actually have a lot of videos on when should you have surgery for spondylolisthesis. If you just Google search or YouTube search my name and that topic, you'll see it. Again, appreciate all the likes coming through. Keep hammering those. It kind of helps promote this to other peers. I can even see the viewer count kind of skyrocketing as y'all do that, so I appreciate it. Sorry for having to cut out, but I do have a family besides doing this sometimes, and so I try to do that role every now and then. Okay, I'm reading some of these questions here. Where am I located? Dallas, Texas. Sandy, do you ever operate on degenerative scoliosis for the lower back? Yes, probably most spine surgeons do. For Miguel, pain only in the lower back, not the legs, to add to the intradiscal injection. Probably an ALIF would be great. If it's a standalone ALIF, that's where we just put the cage in here, so something really fancy like this. One time I actually said the name of one of these cages, and I got this like weird block on TikTok that I was promoting a brand without their permission. It was the weirdest thing. So my longtime subscribers, and I see you guys in here, are going to know exactly what I'm talking about. So I'm not going to mention the name of any products, but the cage goes in here just like that. Again, so if you're walking in, you lay down, you have the approach surgeon, incision's pretty small. You go in, put that spacer in there so it kind of looks just like that. That gives you the curvature, lordosis, so it's fat in the front, skinny in the back, curvature. That's a big deal. Again, those sending gifts, please stop sending gifts. I don't appreciate it, but save it for other people who are more in need. It's probably just a quick way to say that. Someone saying, please reply to my chat. I don't see your chat. Sorry, I got about 1,000 people in here in the different platforms. I actually don't see your question anywhere from Superfan YouTube. It's an interesting name. What do you do about foraminal stenosis? Physical therapy, chiropractic therapy, deep tissue massage are all good. Steroid injections are great. What's my thoughts on spinal decompression? I don't know what you mean by that. Is that like a laminectomy? Laminectomies are great. Thoughts on spinal decompression? Are you talking about surgery, or is that talking about procedure? Do you use the Orthofix back jack? You might mean spine jack from Orthofix. Is that from Orthofix? I don't know. I don't know what the back jack is. I know what a spine jack is. That's like if you have a compression fracture, you put in this implant that opens it up. Um, I don't like it at all, but I don't hate people that use it. In fact, I probably have a couple of my buddies in my big spine group chat that use it. I just don't love it too much. I kind of like the idea of just doing a kyphoplasty. There's also some role for, instead of, if you have a compression fracture, um, actually backfilling it with a mesh bag of bone and putting some cadaver bone in there. That way there's no implant. Yes, technically that's an implant, but there's no metal material. And if you ever need screws through that vertebral body in the future, then none of that stuff's in the way. So I think actually that's a pretty slick way. Adhesive arachnoiditis, I apologize. I don't treat that. Mark. Sorry, I'm not wearing my glasses. So, and again, these names are kind of popping up. Again, appreciate the likes and sharing this. It's really helpful. From Penny, spinal stenosis and spondylolisthesis 4-5, had 3 steroid injections, pain, especially at night. Why? I'll get to that. Any minimally invasive surgery, neurosurgeon said cage fusion, disc replacement. Penny, I would definitely recommend surgery if you've gone through all that stuff. Sounds like surgery would be great. In terms of, do you need fusion or just a laminectomy? It's a little bit based on you. It's a little bit based on surgeon's experience and a little bit based on your x-rays and MRI. So I just don't have a great answer for you without seeing the images myself, but wish you the best of luck. What about FBSS after several failed microscopies? FBSS. What about FBSS? What is FBSS? What is FBSS? I don't know what that means. If you can just tell me what FBSS is. SI fusions or no. Lots of pain. Epidurals aren't helping. From, well, your name went away already. Kind of touched on this earlier. I definitely support SI joint fusions, but I highly support a spine surgeon leading the charge there, and a spine surgeon being the one to recommend surgery, and they kind of go from there. Ring dinger. Yep. Ring dinger. Someone keeps saying the word ring dinger in here. I agree. Ring dinger is a thing to talk about. Radio ablation. Someone said that. I don't know if these are questions or they just want me to talk about it. My favorite thing to talk about, maybe second favorite, L5, S1 anteriosthesis. I guess people are saying topics and they just want me to talk about it. Okay. What's that? He goes bone, disc, bone. And at L5, S1, I'm just use this top one, but that'd be the lower one. That's kind of when you have something either in the joints or a pars fracture that's causing it to slip forward. And that leads to accelerated wear and tear of the disc space, loss of foraminal height. So these nerves, they're nice and open nerve tunnels. They come down, they start to get pinched. Also, this is just a model, but you can see it's like curved backwards, right? All these pictures you see of spines, they're curved backwards, lordosis. The discs are fatter in the front, a little skinnier in the back. So it curves it back. When you lose a lot of your disc material, it starts going down. So now more stress goes through 4, more stress goes through L3, L4. So sometimes, many times, hopefully always, the fusion or whatever the surgery is, but the fusion would be the best, puts in that spacer there and curves you back and actually takes less stress on the other disc space. So definitely a great role from that. Thoughts on OMFS? I don't really have any thoughts on OMFS. The oral maxillofacial surgeons, I don't really have any thoughts. I think they're fine. I wasn't ever too interested in that field, so I think they're great, but I don't really have any negative or positive thoughts. Do I use navigation? Pretty much for 80% of the pedicle screws I placed, maybe 90%. I use navigation. Navigation is great. I think it's less radiation to the surgeon, to the team, to the anesthesiologist, because I'm not too interested in working my butt off for 10, 11 years after college to get the training, I got to go. My kiddo's up. I think I got to run. Okay, follow along, guys. Wait, is he going to go back down? I just can't tell. He's sitting up in bed. But yeah, I navigate every screw. All right, I'm going to start to unbutton my jacket so I can run out. Is he going to go down? I think he's going to go back down, everybody, so we can continue onward. What do you mean 11 years? Oh, 11 years, sorry. So 4 years med school, or 1 year research, counting that one. 4 years med school, 5 years residency, 1 year fellowship, or is that the 10 years? 10 or 11 years. Who's counting, right? Between that, but 10 or 11 years after college of additional training after college to become a spine surgeon. So in terms of using navigation, I like using navigation because it's less radiation for the surgeon. And I can tell you the name, I'm not going to, 4 or 5 surgeons, spine surgeons I know that have had just weird cancers in their like 50s and 60s. And maybe they would have gotten anyway, but we use a lot of radiation in our field, and that sucks because cancer sucks. I mean, I don't need to defend that. So if I could find ways to reduce my radiation exposure, they talk about doctors all the time and all these things, but the workplace hazards is we're just suffering from all this radiation and all these weird positions we have to be in to do our surgery to help our patients. And sometimes the patients aren't super appreciative, which we get, but there's just a lot of radiation in this field. And that's one of the many reasons why sometimes people argue there's a difference between genders in the field, is that there's just higher radiation levels, and they're cognizant of that. But that's something I think about all the time, is just not getting taken down by some weird blood cancer or some weird GI cancer from all the radiation we do. So that's one of the major reasons I use navigation. And when people are at home, are like, what are you talking about? What's navigation? Navigation means I use a screen, or I actually use this fancy headset for augmented reality to help navigate my screws. I can see the patient's anatomy through a screen. This is actually a pelvic screw. They're not this big. This is the difference. See, this is pelvic screw. This is the screws. To put these screws in here through the bone, just like that. It'd kind of go just like that. And these screws go in to help constitute a fusion. So I like the navigation. It's safer, more accurate, and more effective in my hands. Someone else, who doesn't use navigation might disagree. They say they're just as fast without it, and they don't need all that expensive stuff, but great for them. So just doing a couple things here. Yes, my x-ray is the same. How effective is the mild procedure from KM? The mild procedure is fine. Again, that's one of those things I would just recommend a spine surgeon is doing. The mild procedure is one of those things created by spine surgeons and now just marketed by pain doctors to say they're doing spine surgery. For those homes, like, what's the mild procedure? It stands for like minimally invasive lumbar decompression, as a fancy marketing name. I mean, how do you not see that at home? Or like when they're telling you, like, oh, I'm gonna do a mild on you, and realize it's like pure marketing, right? It's pure marketing. If you need surgery, you need surgery. I would just get surgery done with a spine surgeon. They kind of, when it's the mild, all they're doing is just scraping this tissue here. I would say, like, look, if you need a full laminectomy and you need a laminectomy to get you better, you should definitely do it. So, again, totally supportive of pain management doctors. They're hugely important, and they help avoid surgery in the overwhelming majority of cases. I just don't like when they're marketing things to do spine surgery. How about that? So appreciate the follows, appreciate the likes, appreciate the shares. That really can help promote this to your peers who might be going through the same stuff. Keep looking to see if he's about to wake up, but still sleeping. For those that don't know, just as a background, I'm a spine surgeon here in Dallas, Texas. Had 2 boys and 1 little girl, and this is the time of day where one of my boys plays at our neighbor's house sometimes. One of my boys takes a nap, although these days might be numbered, and our little girl takes a nap also. So that's when I jump on here to do these lives, maybe 20 minutes at a time, 30 minutes at a time, sometimes Saturdays, sometimes Sundays, and just try to answer some questions. Yes, we do telemed. Yes, we do in person. Yes, we do remote visits. You just have to reach out to our office or direct message me, and I can connect you with our team to do that. So for those jumping in, spine surgeon here in Dallas, and let's kind of get to a couple more questions. Appreciate the likes, appreciate the follows. What music do I listen to in the OR? I actually have a couple different Spotify playlists. We rarely listen to them now because I used to update them. Now I don't. And now I just say whatever they put on is good. In one hospital I go to, we always listen to punk rock because that's kind of what I grew up with in high school, and it's reminiscent. The Spotify playlist is called Spine Music Festival, and there's 1, 2, and 3. When I was first coming out, I used to update it all the time, and we had new music. Now I haven't updated it forever, and it's kind of the same stuff over and over. What does that mean? Is that Henry?
Yes, can I have them?
He's not home yet. I just checked our text.
Oh, right.
He's home if you want to send him over. Yep, he's home. You can go over. But wear your shoes, please. See, TikTok Live. You get to see a little behind the scenes of what's going on in my life, which is nice. I think that's kind of a nice thing. Most of the time you meet your doctor, you meet your surgeon, and all you know about them is what it says online. It might says they went to prestigious Ivy League spine center, and how do you know at home if that's even a good one, right? It's something where I don't want to say any of them because I don't want to get in trouble, but just because a place has a good undergraduate reputation doesn't at all mean they have a good spine surgery department, and vice versa. You might go to I'm making up these names because I don't want anyone to get mad at me. The blue pin for spine surgery training, and that could be the world's best, but people at home would never know that. So that's kind of why the social media aspect's nice. You get to kind of see behind the curtain a little, meet your spine surgeon, hear how they talk before you even have an appointment with them. That's kind of a nice way to kind of see. But that is my little boy running in here now, going to play with one of his buddies, which is great. Our facet joints sometimes very weak due to weak bone development. Yes, but not really. Maybe, but that's pretty. It's just not that common. I don't know what to do with that question, honestly. They could be weak, but not really. From Sean, can I ask a question? Sure, Sean, go ahead and ask away. And if I miss it, just copy and paste it and try it again. Sometimes I missed it. What's the highest paid specialty? OMFS? I don't know. I think people say neurosurgery, like as a broad generalization, and that's a tad different than, they usually don't separate, not to get too complex here. They usually say neurosurgery and like others like orthopedic surgery. I'm an orthopedic spine surgeon, so I don't know where orthopedic spine surgeons fall in that. Are we falling under neurosurgery? Are we falling under ortho? But usually they say neurosurgery. Part of that is, again, very broad generalizations. When they take call, they're taking brain call. Like if I took call, I wouldn't take call for the brain. I'd take skull all the way down. And brain call pays a really good amount each night just being on call. And that might vary. You might be institution employed. You might be, employed by university health system. That's just, you have to take call and you don't get any additional payment for that. So I'm not trying to really at all for real talk about that. That's sometimes where those elevated appropriately numbers come from is, they're on call in the middle of the night and have to run in and drill a little hole in the brain to evacuate a hematoma. So I think but I think that's something Chat GPT or Google could answer. I don't know, but I assume then. Can I get advice? Someone keeps asking a good question. It's just coming in fast from Paul. Can I get advice, please? T7 collapsed. The spinal cord runs onto it. What would you do? Paul, I can't give formal advice, as you could imagine. I would just say I'd get with the spine surgeon and see what they say. Probably something where you need both. They get x-rays in their office, but probably a CT as well as an MRI. The CT would show the bone structure to show the amount of fracturing, and the MRI, which is more important, actually shows the spinal cord and if it's new. Is Lewy body dementia hereditary? Goodness. Well, at one point in my life, I studied that really, really hard to know all about Lewy body dementia. And that was in medical school. And I don't think I've studied the background of it much since then. And that's why you study really hard, is so that you can get into one of those fields where you don't have to know all that stuff. I say, so I don't know. I would Google search that. I really just don't know. Someone said, Linda, I had an SI joint fusion, still having the same pain. Any thoughts? It's probably not your SI joint then. If you're like, I had a right SI joint fusion and I have the same pain after, well, it's probably not your right SI joint, because unless your fusion didn't fuse or they did it some weird way, there's like assuming that SI joint fusion is perfectly healed, then it's not your SI joint fusion. That's like saying, well, I don't want to get into that. Either way, that's not your issue then. So that'd be my first thought. Kyphoplasty thoughts. I like kyphoplasties. I'm not trying to do them. I'm not trying to be the hero in Dallas for doing kyphoplasties, but if they come into my office and they want them and I can not talk them out of it, I do them all the time. Facet joint replacement. I'm not sure. We'll come back to that later in life. After watching Dr. Death, I'll never have any type of spine surgery. I hope you never have to get one. And, I was a neurosurgeon, and that was definitely a bad situation. But I don't know. It's like saying, after reading about Bernie Madoff running away with everyone's money, I would never invest my money or save my money with someone because they're all bad, and I don't want that to happen to me. It's like, all right, well, good luck not investing your money, and just, I don't know. We don't need to get too technical on that. I don't have a great analogy. It's like saying you saw a show about someone's car that went to the shop and broke, so you're never going to take your car to the shop, like in the entire world. Like, okay, fine. That guy was a psycho and kind of cheated and was a neurosurgeon that didn't have the checks and balances. So fine. Jen R, have you seen collapsing spine syndrome? I don't know what collapsing spine syndrome is from Jen, so I'll have to look into that. I don't know what collapsing spine syndrome is. I do have to go here in a couple moments, so I'll get to a couple more questions. Have you heard of epidural lipomatosis? My son was diagnosed at 9. I have heard of that, but I didn't know 9-year-olds could get it. Usually, again, I don't know anything about your case, but usually epidural lipomatosis is pretty obese people, heavy people, and that does cause spine compression. But I want to hope that 9-year-olds develop that much tissue there, but maybe some people can be born with it. I don't know. Do you think any sort of cell therapy in the future will truly help with DDD? I do think in the future, for sure. Like, it wasn't more than 10, 15 years ago where there was no cure for hepatitis C. And if you got that, there was no cure. Now there's cures for hepatitis C. It wasn't too long ago where, if you have HIV, it was game over. Now we have pretty good treatment. And then I kind of think there's a vaccine for HIV. I'm actually not totally sure because it's not really my field. But the only reason I mention that stuff is it's not crazy to think that there could be a good cell therapy for degenerative disc disease in the future. If you're then wondering, well, what about now? Is there good stuff now? I don't know. I'm not like, if you got tons of money, if you're willing to spend $10,000, $15,000, then go for it. And I'm not trying to be the bad guy for, I don't do it. I'm happy to, if I did it, you make a ton of money, make a ton of cash. And if it doesn't work, fine. They still get spine surgery. So I'm not trying to talk people out of it. I just haven't seen in any high impact journals, like there's probably like 6 or 7, the ones we actually care about, the ones we spine surgeons actually read because they're not garbage, that show that stem cells can reverse disc degeneration in like active live humans. So again, I'm not against stem cell therapy. If you got tons of money, or if you're like so opposed to spine surgery, you want to spend all your hard-earned money, then great. That'd be great. Let me ask a couple more questions. I do have to go. I have a pars fracture. Do I need to do anything about it? If you're not having any pain, Jordan, no. But if you have a pars fracture and you are like in 16, 17, yes. If you have a pars fracture and you're like in your 40s and it doesn't bother you, then don't worry about it. I'll just think of it that way. Hi, doctor. So random, but what's your favorite surgical instrument? Oh, golly, I used to have this answer. You feel like I would know it off the top of my head. I don't know. I have to think about that. Probably a Murphy ball probe. That's kind of boring. Or a curved curette. How about that? I think a curved curette is my favorite instrument just because you can do so much with it in terms of what you need. There's also maybe a deep Gelpy. I know I say I'm a minimally invasive surgeon. That's a big open surgery tool. But a deep Gelpy, a good deep Gelpy is great. Is it always anesthesia's fault? Maybe. Kind of the nice thing about different areas, if I could just do a little plug for myself, which I don't like doing, is here in Dallas, it's actually at many of the hospitals, it's called an open anesthesia system. And so like the spine surgeon brings in their own anesthesiologist or their own group. Well, why does that matter? You might at home not know that's how it doesn't work elsewhere. But normally it's like, your surgeon, if it's at UT Southwestern, for instance, they have their own department. And so it's just whoever is the resident or attending on call that day, or let's use a different place. Some of these centers have a contracted group anesthesia, and that's like a ancillary for that institution. And so you just have to get whatever anesthesia shows up that day. So it is easy to blame them because you've never met that anesthesiologist. They've probably never met you. They're employed by the hospital. Great. Well, it's nice here in Dallas. Many of the hospitals are called open anesthesia. So the surgeon can bring in any anesthesiologist they want. Why does that matter? Well, because for the most part, I have the same one or two, sometimes a third, but the same one or two anesthesiologists for every single one of my cases. So they know exactly what I want. They know exactly, they help me with positioning the bed, rolling the bed, and pretty much just the same protocol, the pre-op medications, post-op medications, not over-medicating the patient. And they actually have like ownership in it because they want me to be happy as well. They don't they're not just there clocking out. They're not just going home at 3 p.m. and the next person's coming in. So that's kind of a nice, weird thing I never even knew of until going into private practice, that it's just a huge, huge difference than, there's the hospital supplies anesthesiologist. And that's how it growing up, it always was, in training, university settings, academic settings. That's how it always was. It wasn't until you get to private practice where like I found out how to bring my own anesthesiologist, how to book them. And that's amazing. That's a totally different game changer. And I would argue it'd be great if society could push to that, but different argument. All right, everyone, I do have to go. It's getting to be that time. I got a lot of stuff to do tonight, and I still have some admin stuff I want to do today before my kiddo wakes up. So this is great. If you enjoyed it, please follow and subscribe. I'll jump on here maybe next week. Can't think of what I'm doing next weekend, but it'd be great, and I appreciate the follows.